So good morning, everyone, and warm welcome to this session today. And it's a great learning. So what are we thinking? What we are thinking is, again, I'm going back to our communication topic. So have we communicated well to the patient? Have we spoken well enough to the patient is what we have to now discuss. We have to now think that everything is about a mind game. 80% of it is a mind game. We have to understand where we are, where the patient is. He has not, we have talked to him and we have told him, oh yeah, I'm there, you can come to me. But we have not told him that, look, have you thought or has any doctor previously helped you in discussing how to manage withdrawal symptoms? There are going to be a lot of societal and there are going to be a lot of social cues. There are a lot of environmental cues. There are a lot of psychological cues or pressures which are going to sometime maybe push you towards grabbing that particular way out. So preparing him in that communication is again important. Preparing a person is very important. What to do in such circumstances and what not to do. Now, what this guy did was he went into a guilt. All right. That is called something which I will explain to you now. It's called an AVE. So I will discuss that with you. So what really is relapse? What is relapse? So relapse and slip. All right. So think about a person falling off the stairs. If he just kind of loses his balance, let's say you are standing facing with your back to the stairway and you inadvertently are in a situation where you're not conscious of the stair behind you and you kind of lose a foot, but you're able to hang on to something for support, which is your staircase banister, and you are still standing. Okay, so you have slipped. But you have not gone and fallen all the way down till the bottom of the stairs. So now these are the two situations which, of course, I am now going to make you apply it to the tobacco patient, the tobacco user. So this patient has now come into a situation where he's got societal influences, he's got social cues, his friends, his party, the smoke of the cigarette, the smell of whatever, the alcohol presence in the bar, he's standing and talking to his friends at the bar, they're actually, so everything is kind of intoxicating him, reminding him these are the good times, everything is good. So he's likely to be able to drawn into it. There's a cue, these are cues. It's not a craving, He's not desperate for it, but it's a cue for him, which is pushing him for it. This same cue can start moving it in a direction that it becomes so difficult for him that he can't resist it and he takes a one or two, like your patient did. So when he takes one or two, the first thing that he has to be able to do is he has to be able to talk to somebody. As we say, he will go through a lot of guilt, or he's going to go through that great, as you said, that elan, that, oh, this is just one of those things. I'll never do it again. Or even if I do it, so what? I'll not do it all the time. So the question is about who does he talk to? So does he have his buddy to reach out to? Can he take his buddy along where he was? And does he reach out to his doctor and has the confidence to be able to talk? So somewhere along in his mind, there is still a wall because that whatever he's done is really wrong. So it should not be viewed as a failure. That's the first thing. We have to tell the patient that. We have to tell ourselves that and learn it, that it is not a failure. So we have to identify what were the obstacles. Obstacles here are the cues. What is it that he couldn't stop? Why could he not stop? Why could he not walk away? What was the difficulty he faced? Was there too much pressure which he could not succumb to? Whatever kind of pressure, social pressure or psychological pressure because of a job or whatever it is. So now you have to modify because now he speaks to you and tells you. So how is that you are going to shorten it? So now remember that a patient or Dr. Pavans also who came 10 days, 20 days before his surgery, and then came back on the day of his surgery and said no. Now think of this patient, he's going for his surgery, he's definitely going through anxiety. So we have to shorten the visits, shorten the number of interactions that we have with him and start getting it closer, stay connected with him. Live in the patient's brain and live in the patient's shoe and understand his mind at this minute. So increase the number of follow-ups with him, keep him connected. So what we say is, when he takes in the process of quitting, now he's process of quitting or he's already quit as in case your patient, yet he ends up taking one or two, that would be considered a slip. That would not be considered a relapse. All right. So what must one learn from these slips? It's very important. Look at those pointers there. Don't be hard on yourselves. What was the panic attack for? We don't know whether he went into a panic that, oh my God, I'm going to be getting this, or is it something more? He's so guilty about it. He's kind of killing himself about it, or he's not, whichever way. So tell the patient not to be hard on themselves and learn from what went wrong. That means being able to introspect. He or she has to be able to tell you just the way he or she tells you that this is my cue, this is what happened, the log was there. So he has to write down, who was it? Out of there were 5 friends. I could resist 3, but I could not resist 2. What is it that they were saying or doing which made me get into it? So where I should take my exit route next time, how I should have that escape hatch to open and make sure that I'm out of that place at that minute. So plan with him, discuss with him, talk with him. This is not possible for us. So your quit coach has to be doing this. Your quit buddy comes in between, chats up with him, maybe writes a few notes in case he or she is still dying with guilt. And that is when the support system has to come in and make sure that every slip doesn't make the patient go into a relapse. So we have to understand a slip can happen, hold it at a slip, don't let it go into relapse. Give that banister, hold the rail so that he stands again. He doesn't fall to the bottom of the stairs. So that support at that minute, positive memory recalls, remind him how good it was, that how well he stayed quit, as you rightly did also. So this is very, very important, the conversation and the communication, the hand holding, the support. Just imagine with your back, what I just gave you the example, that you're with your back to the staircase behind you and you just started to move back while discussing with somebody something and you didn't realize, and one step down and see what happens to your heart, and you quickly try to hold on to things. So here, slip and relapse, the difference, and make sure that we have to make sure that no, every slip is not going to go into a relapse. And when a slip happens, recognize a slip, communication about it. This is what your patient can, most people have to will go through, is a AVE effect, which is an abstinence violation effect. He was supposed to abstain. He violated. He undergoes, he starts thinking he has no willpower. He starts kind of denigrating himself. He's down in the dumps and he starts becoming really, goes into a complete mess at that minute. And in this process also, he might just, his entire being might be suffering and he might just go back into a relapse. So make sure that the patient is not getting into an AVE. You have to be very, very sure. So you must be aware. So creating an awareness as to what was it in the environment, who was in the environment, was it a smell, was it a person, was it a word, was it an item, what really caused this that I had to go into it. Learn how to control these factors. You have to tell them that. And not to lose control and to again retain back focus. So communication, handling of the patient, not allowing the patient to get into AVE, because from an AVE, what was just a slip can actually become a relapse. Okay? Yes on this?
Yes, ma'am.
So what is our role? How do we do it? Obviously, hey man, you couldn't even control yourself. What the hell? You go to one party and you just go see one bottle of scotch and you can't stop yourself, is it? What the damn hell is this? No. I worked so hard for you on 2 months. You worked on yourself and then you go and let it all down. No. No judgments. No judgments. Help the patient. Make sure that the support system, he doesn't feel he is now, without any help because this has happened. So take smaller steps, make small goals, help him out, teach him how to manage this AV so that he does not get into future slips and never into AV. Because AV is going to make sure is that slip into a relapse. So no negative feelings. It must be that he starts introspecting on this positively. That is strategizing. Why did it happen? How did it happen? What should I do next time I see my friend Naresh? And this guy is the one who is every time talking about cigarettes. And he talks about how good it is and how this it is and how that it is and whatever. And he holds the best cigarette packets in his hand and it draws me to him. So this is the guy I have to watch out for. Either I take the exit route, I don't want to meet him, or I make sure I have got my everything in place at that time. So introspection, everything about managing that situation well and learning to introspect on that. Okay. So we know this, what can be the pressures, we know that. So exactly the same thing. So we have understood this very well. So it is about learning to cope with stress, learning to cope with situation, introspecting about it, taking an escape route out of it, not going into an AVE, learning that a slip can happen, communicating about the slip, feeling confident to communicate about it, that my doctor will handle it and he will make sure that he tells me how not to. And or empowering him, and this is your role now, to empower him to make sure that he doesn't, next time he can avoid a slip and certainly not go into a relapse. These are causes of relapse. We all know what this is. Alcohol use is one of them, because alcohol and cigarettes go together. Tobacco, we know, is the gateway of drugs. So anything, once a person has tobacco, that gateway has opened and every other drug can come in through that. So that is how it is. The higher levels of drugs keep coming in. So many times because the cessation was ineffective. So you see, he may have quitted because, as you said, he had good willpower, but he didn't have a support system to help him stay quit. He did not know what is to be done in case there's a slip. Nobody told him this, what is a slip. Nobody told him how to handle that situation. And there are situations when there is a buddy is not good enough. The buddy has not stayed with him. He's come to a party, the buddy has gone with him, the buddy has walked off because he's found his friend, or he's seen some girl somewhere, he's walked off. So the buddy, instead of staying when in his situation of distress, the buddy is partying somewhere else. So buddy has not been the proper one. So there are many situations like this. You need to be able to introspect, ask the patient what it was, and work on this. So now here's your patient. Relapse can occur months or years after quitting, not necessarily immediately after quitting the habit. So that slip, when it happens, make sure it doesn't go into a relapse. This is where it happens. Office, parties, public places. It happened in your case, in your patient's place because of this. So many people in the COVID have gone into, because of the loneliness, they didn't know what to do. So they've gone into smoking all kinds of stuff. Every kind of stuff you've heard of. They've gone into different kinds of stuff. Then seeing the store, that is one of the biggest, biggest cues, seeing that store. So responses to some common relapse problems. So it is basically, it's all about, see, whatever may be written here, it does not matter. What you have to know is, how am I going to practically handle it? Practically handle it is empower the patient. Ask him, not the stress is not the way out. You have to sit down, maybe take a checkbook list and figure it out. Maybe the buddy has to work along and figure out what were these feelings, what were the cues, who was the person, not to feel depressed, but to now strategize, realign, reimagine how am I going to be working with my doctor and my counselor, my quit coach, and work. And the same works for the quit coach. I have to realign, re-strategize. Also the same is for the doctor. That now a situation has come up, this didn't happen earlier. So how do we handle it? So what went on? So what do you think will help? So why not ask the patient? How do you think this thing we can avoid? So you get him thinking. Again, open-ended question. Oh, don't worry, such things happen, but I am there to help you. But if I give you the remedy, maybe that may not be the working thing for you. So why don't let's brainstorm, and let's kind of brainstorm and find a device as to what do you think is going to work. So get him chatting instead of getting him into negative modes. So important thing is always is the support. The support has to be there. Keep a follow-up, reduce the intervals, stay connected, send a motivating message in the morning, and referral doctor should be around, give the correct medication if there is any such problem, treat the comorbidities, because wellness has to be worked on, not just tobacco cessation. Work towards wellness, holistic wellness of the patient, overall holistic. So prescriptive relapse prevention is, focused basically strong or prolonged withdrawal symptoms that the patient is having. So what kind of a patient do we have here? Assessment of the patient. Is he taking what is required? Is he having the withdrawal symptoms, which is very high? Now you remember, when the patient is having a very strong craving, we say give the NRT, give it, nothing will happen. Practice 4D, then this is out of the 7 Ds, we say practice these at least, drink fluids, by making it, delay what has to be taken. So delay everything, get into a walk, distract, start talking to the buddy. Then substitute. All of you have just discussed a whole number of substitutes which have been discussed, from tamarind seeds to chia seeds to everything. So substitutes, if the person is a chewing person. If it is hand to mouth, if it's a smoking thing, then you know there are many things which can be given. You give sticks, carrot sticks. You can give the cucumber sticks, cut them instead of in pieces, in sticks. So hand to mouth. So you're able to take care of these things. So basically, substitution, mouth substitution is what is there. Weight gain, how to handle weight gain. We have discussed that last time also. Exercises, weight loss. So this is something that we talked about. We had Dr. Richa coming and speaking to us. We had a very, very nice session with her. So you know everything about diet. Flagging the problem, never feeling deprived, never feeling, so be able to enhance the confidence. So what, as I said, is, empower the person basically to regenerate your own dopamine. So you don't have to kind of depend on tobacco for your dopamine. You need to be able to find your ways, whether it is poetry, whether it's singing, whether it is dancing, whether it's meeting friends, whether it is doing whatever, but enhance your own dopamine surge, and getting the reward coming from some other means. Using the 7D, you can distract, delay, whatever, but there has to be a method of, by exercising, by, playing games, meeting friends, doing good things, and also remembering, maintaining a journal of all the good things is very important. Keeping a picture album of a holidays that they went for, they work well, they work very well. They have worked very well, picture album, because they really take you back in time. And the good picture albums, where you honeymoon or some such nice things where there has been no cigarettes involved in there. So those picture albums are also very good. How to identify, basically what we just discussed. The triggers, cues. Patient should have the confidence to be able to talk to us. Never get judgmental. Never let him know, oh my God, I cannot tell him. Never let it be like you're a parent. You have to have a friend attitude. You have to be the doctor's attitude. You have to be the supervisor's attitude, but not. The question was asked whether I have to be a friendly person or whether it has to be so it was firm, friendly, yet at the same time guiding and facilitating. So that is how the relationship has to be, not about being judgmental. So nicotine craving, how should the patient handle it? Of course, 7 Ds, of which the 4 Ds are there. NRT, munching, we know that. If it is a smoking thing, engage the mouth to hand activity. If it is a chewing thing, steal the mouth by putting chewable stuff. Anger, frustrations often come out very well by doing activities even like ironing. You really can take out a lot of anger. Having a hot water bath or having a cold water bath, a foot massage. Medications, of course, is always there. Anxiety. Now, anxiety. So many times in these patients, we need to check about their caffeine intake. When was the last caffeine intake and how much is their caffeine intake in the day? It's a very critical factor to be checked into, because these patients who are going into anxiety, and many times caffeine is very highly dehydrating, you're aware of it. So the patient is parched throat, parched this thing, and then the situation also has happened, something like this. Everything put together adds to the stress factor, adds to the, acetylcholine, and we are out with a whole stress gamut over there. And there is a hijack which happens. The patient is either getting into a ABE or running back and taking exactly the same product which we're trying to get him out of. We have discussed weight gain. We have discussed dry mouth. We've talked about the Aquazil gel, the lozenges. We've talked about that. You can give it. It's all good stuff to just keep in the mouth, even sugar-free candies or gums, because you should not give anything with sugary stuff, because these patients have, as it has got a very bad oral hygiene, and then they tend to have a lot of periodontal disease by itself, and now they will start getting caries also. And if they're using e-cigarettes, then dental caries is definitely very high in these patients. So in fact, that's also something very good to watch out for as a signal when you have a patient, a very young, fashionable person, and you have a lot of fruity smell around that person, and you see a lot of caries in there. Please remember to ask the question about use of e-cigarettes, because e-cigarettes have a lot of glycol in that, and then what happens is that part of it makes, and the sweetish flavors and things like that, which makes caries, even hookahs. So remember to ask these things. Sleeping disorders, well, very close to my heart. because that is what brought me into tobacco cessation. So how do you kind of get the person to have a sleep hygiene? So tobacco use and sleep is very closely related, even though it's not talked about today yet, not talked about yet. So that is something I have with Dr. Pavan, because every time I even say that we'll have a discussion on this, he'll say, no, we'll do it later, another time. So the sleep disorders and tobacco use, and it is going to blow. It's going to become big because I know it exists really high. So people who are dealing with such patients also, you should be very aware of that and see how to get a sleep hygiene back. Because once you get a sleep hygiene in there, a lot of the regulation will happen. And then the tobacco use will also be cutting down at the same time, because you have to handle both simultaneously. Be conscious of this. Difficulty in concentrating, the problem there, and headaches, how to manage them. So the whole thing is not being anxious. So Sudeep, I think this is where I want to stop sharing and I want to talk about it, because when the patient is anxious, oh my God, I'm going to a party, I'm really scared now. What the hell is going to happen? I'm going to meet these 5 guys, and these 5 guys, the last time I met, I took these cigarettes and I took that and I just couldn't stop myself. He's already built the anxiety into his system. So it is about being alert, but not anxious. So we say it is being calm, being aware, but not anxious. So this part of the communication is very important, that don't worry, be aware. If you worry, you're not going to get anywhere, because you've already increased the stress level in your body. And now stress has to be managed by you. Oh, these guys are again coming up in front of me. The last time was really bad. I couldn't stop. I took 3 drinks and I took 4 cigarettes. So no worries, but you have to have that patient now being able to discuss things with you, at the same time being in a relaxed state, but being aware. So we need to educate our patient, encourage them to be fully aware of their circumstances, the way you would tell a person, the way you would tell a child that, look, you're at the staircase, be careful, you might just fall. Just be careful in case you slip, or otherwise just face towards the staircase. Don't have your back to the staircase. Is the same thing here. It's about your communication style, communication, and your concern, which is being put out to the patient, such that no anxiety is being created, awareness is being created. Do not put a guilt in. If something happens, say it's a slip, we can handle it, provided you come back and tell me. If you don't tell me, we are both going to be losers, because it might become a relapse. So this communication is a very, very important communication component, which has to be informed to the patient. I will just put up the last 2 slides, and then we are done for today. So this is what I talked about. This is, how are you going to do open questions? So that's what really happened. Don't say, why did you do it? So what happened that time that really, that kind of, it wasn't so. So now this habit formation, changing your hours. So changing the hours in case now he is going into a slip, or, if there's the slips are, the relapse, or the slips are happening more frequently, he's not able to kind of handle it. So you need to know what has to happen. So what is the cue? We have to remember what is the reminder which is now creating this problem, which is happening in him. What is it that the patient is doing about it, and what is the reward? So change this entire 3 hour of the habit formation. Change this reward cycle. Changing the reward cycle would be like, okay, I have this guy with me over here. This fellow reminds me of taking, or pushes me to take a cigarette, saying nothing will happen to you. Oh, you can so easily give it up. He pumps you up so much that I end up taking it, because I realize I can't finally. I feel so bad about it. So it is better at that time, say no, or just learn to keep a glass of water with you. Because when you keep drinking something, your throat is not going to get parched. You're not going to be able to get into a sense of some kind. So you help the person to manage that. At the same time, change his habit cycle. That, okay, when I cross that road, I get this thing. So take another route. Benefit, what is going to happen. So all of this we have already talked about, but basically you need to know that the 3 hours of a habit formation, which is there, that is the reminder, routine, and the reward. So you kind of rework on this completely. We understand that. How do you strategize? So first thing is, of course, do not allow anybody who's, smoking inside your house, because that person is not only going to make the environment bad, but it's possibly going to leave some kind of smell around, which is going to act as a trigger for you. Do not allow any tobacco to be carried. Try and avoid people who you think are going to be very pushy and very, forceful about it. And of course, being very important, very, very important is to stay alert but relaxed. Relaxed alertness is the cue for here. And we need to be able to do that, have a drink. Don't take an alcoholic drink. Don't take a sweetened drink because that can cause a lot of, or if there's only a juice available in that particular party at that time, put half juice and half soda or water and make it diluted out so the amount of sugar reduces. Try and take things without all of that and keep away from, and what being aware is what? When is it that the patient is more likely to do this? Because when you're lonely, when you have nothing to do, boredom, these are again areas and times where the person can slip into such a situation. So get him aware of these things. Tell him that, if he's going to be alone for a while or something, it is, and again, telephone. So because one hand is free, so those fellows who are smokers always have something in the hand. If there's a glass in the hand, then the desire to take something else. So getting them aware of the situation, helping them to manage it, not getting into a guilt, not getting anxious, but being aware and being relaxed and aware of things. All right. So with this, I think we are close to the risk and the relapse and prevention, as well as learning what is slip and relapse. Most important thing is communication here, the creating the awareness and avoiding AVE. Abstinence. He should not get into a situation where he is dying of guilt now. And in such situation, close up make it closer, make the follow-ups closer, be in touch more, get the buddy. What has the buddy been doing that day? So why wasn't the buddy, been able to control it? What really went on? Was the buddy not good enough? Was the situation more drastic than what we thought it to be? Were the guys more pushy? Who amongst them were pushy? So to isolate, identify, and to take strategize for the next time. Do you want to say anything? Because you would have seen patients like this. You want to put in something from your experience?
All the pointers were covered because normally such patients, in terms of follow-up is the only thing. We just keep talking and keep reminding, positive reinforcement of everything. We have discussed so far for such patients who actually undergo a slip. The only thing is that the guilt feeling which is there in the patient, they have to overcome that guilt feeling. And whenever the person experiences the slip, they have this very bad guilt feeling. And when, as a quit coach, I follow up these patients, they always have something to add to the story. So the most important thing is to empathize and say that, and to explain it to them very positively that this is not a relapse. A very clear-cut distinction that this is only a slip and can be managed. We just have to assess the situations, why this has happened, and what factors can help you manage similar situations or the same situation you're in the future. So, ensuring that the patient is able to observe their vulnerable situations, come and discuss to you, ensure that they honestly discuss their feelings about guilt and also their feelings about how they feel when they slipped over a couple of pouches or maybe a couple of sticks, and how it can help them. So this is one of the strategies which has really worked out for patients who are slipping during the treatment process. And for the second case where the people are actually undergoing a relapse, meeting them in person has really helped. We had a very few cases where we saw the smokers and the chewers relapsing, and in those cases, online consultation, when meeting them on a video mode if they are not in and around the area, or otherwise calling them to the center where you are, or where you sit into your clinics, is the best ways of having a great discussion with them and knowing and finding out from them what exactly has been the reason why someone has been really facing the relapse, or why they have undergone relapse. These strategies have worked, all practical strategies that I can get, and that is what I would suggest, that this can be practiced in your regular patient interaction to help them differentiate between the slip and the relapse, and then to manage both the situations successfully. Yeah. Thank you so much, ma'am. Over to you.
Thanks, Shruti, for giving that closure.